Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. This will be the final of 3 episodes on sarcoidosis for board examination review. On the prior episodes, I have covered sarcoidosis manifestations in the chest, cardiac manifestations of sarcoidosis, and findings related to CNS and head and neck sarcoidosis. On this episode, we will discuss abdominal and pelvic sarcoidosis, musculoskeletal manifestations of sarcoidosis, and conclude with a few thoughts on cutaneous sarcoidosis. I have made a unified, free downloadable study guide on sarcoidosis covering all of these organ systems available on my website, theradiologyreview.com. Please go to my website and download that. I have also recently added on my website the Radiology Review top books in radiology for 2020. And what this is a collection of books for each subspecialty in radiology, as well as some additional books for radiology research that I think are worth your time checking out. Without further ado, let's get into this episode. First question, true or false? Sarcoidosis can involve any abdominal organ. The answer is true. Based on my best guess, on board exams, you might be most likely to be shown liver manifestations of sarcoidosis if they are showing you a case of abdominal or pelvic sarcoidosis, but you should be aware that sarcoidosis can involve any of the abdominal organs. If you see a liver lesion, or for that matter, any solid organ abdominal lesion or a peritoneal lesion, and they also show you chest imaging showing mediastinal and hilar lymphadenopathy, you need to consider sarcoid high on your differential diagnosis for the board exam question. Isolated solid organ abdominal disease without thoracic manifestations of sarcoid is rare, so you typically would have abdominal plus thoracic manifestations of disease. Next question, true or false? Sarcoidosis can cause cirrhosis and portal hypertension. Think about that for a moment. Can sarcoidosis cause end-stage liver disease with cirrhosis and portal hypertension? The answer is true. In the setting of chronic liver sarcoidosis, you can have cirrhosis and portal hypertension. And in general, again, as a reminder, if you are encountered with a question asking whether sarcoidosis can do basically anything, the answer is typically yes. Sarcoidosis can manifest in so many ways and involve so many different tissues in the body that you need to be aware it is a great mimicker of many processes. And with chronic liver involvement can cause cirrhosis and end-stage liver disease. Next question. If sarcoidosis involves abdominal solid organs, what is the most common imaging manifestation? Think about that. How does sarcoidosis present in the abdomen and pelvis in terms of abdominal solid organ involvement? The answer is that you would expect to see sarcoid granulomas, and they commonly manifest as numerous small mass-like nodules or overt masses in the organs of the abdomen or pelvis. Additionally, these nodules and or masses can also involve the peritoneum. You can also have lymphadenopathy in the abdomen or pelvis, and you can also see organ enlargement to include hepatomegaly and splenomegaly, and those organs would typically demonstrate a heterogeneous parenchymal pattern with or without discrete nodules. Next question. What other entities can present similarly to sarcoidosis in the abdomen and pelvis? What is on the differential diagnosis for abdominal and pelvic sarcoidosis? The top things you should think of are lymphoma, metastatic disease, and other infectious etiologies to include mycobacterial infection and fungal infections. In general, on board exams, remember that both lymphoma and sarcoidosis tend to be mimickers of other disease processes and can also mimic one another. So we often need biopsy to differentiate what is happening. Next question. Gastric sarcoid can present with the appearance of Leninitis plastica. What is Leninitis plastica and what other disease processes can result in this appearance? Leninitis plastica of the stomach typically results from diffuse gastric adenocarcinoma that involves the submucosal stomach and causes diffuse thickening of the gastric wall. So with Leninitis plastica, you see diffuse gastric wall thickening. Differential considerations for Leninitis plastica include metastatic disease, again, lymphoma, other granulomatous disease, and Crohn's disease in gastric amyloidosis and sarcoidosis. So many things can cause Leninitis plastica, including sarcoidosis. But the first thing you should think of with Leninitis plastica is diffuse gastric adenocarcinoma. On a barium fluoroscopy study with Leninitis plastica, you would look for inability of the stomach to distend, and you would look for loss of normal gastric mucosal folds. On CT images with Leninitis plastica, you would look for diffuse gastric wall thickening with possible perigastric lymphadenopathy. Next question. Sarcoidosis of the kidney can result in what laboratory abnormalities on blood and urine analysis? In other terms, if you have renal sarcoidosis, how can this manifest in the blood and the urine? The answer is that renal sarcoidosis can cause hypercalcemia and hypercalciuria, along with renal calculi. The physiology is complex and beyond what I think you need to know for the ABR core exam. In severe cases, renal failure can result from severe granulomatous nephritis from sarcoidosis. But on a question stem, if they give you hypercalcemia and hypercalciuria and show you findings that could be consistent with sarcoidosis, you need to consider that as a possible answer to the question. Next question. Can sarcoidosis affect the testes? The answer is yes. Sarcoid can involve the testes and epididymis, and it may manifest as multiple hypoechoic lesions within the testes or within the epididymis. Differential considerations again include lymphoma, metastatic disease, and other granulomatous disease. Note that sarcoidosis can also cause abdominal and pelvic lymphadenopathy, and that lymphadenopathy would be FDG avid on a PET scan. And you can also see peritoneal nodularity and even ascites formation. Again, sarcoidosis is a great mimicker in the abdomen and pelvis. Biopsy is typically necessary with these findings to confirm what the etiology is and to exclude malignancy. Next question. Sarcoidosis is one potential cause of medullary nephrocalcinosis. What are other potential causes of medullary calcinosis? A mnemonic exists for medullary calcinosis that is commonly out there, and this is HAMHOP, HAMHOP. The H stands for hyperparathyroidism. The A stands for acidosis, such as renal tubular acidosis. The M stands for medullary sponge kidney. The H stands for hypercalcemia and hypercalciuria, and that can happen with sarcoid and milk alkali syndrome. The O can happen with oxalosis, and the P, papillary necrosis. Again, that is a mnemonic to remember causes of medullary nephrocalcinosis. If you don't know what medullary calcinosis looks like, go ahead and do a Google image search and find out. And remember HAMHOP. Download the study guide to review this again or rewind and listen to it one more time. Note that medullary calcinosis is way more common than cortical nephrocalcinosis. For a quick review, causes of cortical nephrocalcinosis are broad, but include renal ischemic injury, renal transplant rejection, infection, chronic glomerulonephritis, nephrotoxic drug injury, Alport syndrome, and other causes. Also, note that calcinosis of the renal pyramids has its own differential diagnosis to include renal tuberculosis, sickle cell disease, overuse of Lasix, and renal papillary necrosis. The differential considerations are important there. Download the study guide and review these on your own and make sure you have these down. In terms of sarcoidosis, sarcoidosis is one cause of medullary nephrocalcinosis, but typically would not be considered high on the list for renal cortical nephrocalcinosis. That concludes my review of abdominal and pelvic sarcoidosis. If you hear background noise, I apologize. I am recording at a different time than I typically do, and there are people out and about. Please be patient with me, and I will be able to provide better audio quality on future episodes. So bear with me at the moment. Let's get into musculoskeletal sarcoid. What are common MSK findings of sarcoid? Can you think of any typical manifestations on MSK for sarcoidosis? The answer is that sarcoid can involve any bone, but the small bones of the hands and feet are more commonly affected. On board exams, pay attention for sarcoid to be shown as lucencies in the mid and distal phalanges, especially of the second and third digits of the hand. These are enchondroma-like lesions, and they have a lytic lace-like pattern. You can also see soft tissue thickening of the fingers or toes, which has been termed sausage digits. As I mentioned, sarcoid can present with multiple lytic lesions. What are other differential considerations for multiple lytic lesions? A mnemonic for multiple lytic lesions that is commonly out there is POEMS, P-O-E-M-S, POEMS. The P stands for Paget's or hyperparathyroidism. The O stands for osteomyelitis. E, eosinophilic granuloma. M, metastases, and I would think of thyroid and renal malignancy first, as well as multiple myeloma for M, and the S is sarcoid. Okay, that is a differential for multiple lytic lesions. The S in POEMS is for sarcoidosis. POEMS is not all-inclusive, but it does remind you of many common entities for multiple lytic lesions. There are other mnemonics that are also out there, including one called FEMHI, perhaps, F-E-E-M-H-I. I'm not a big fan of that one because it's so hard to remember FEMHI. It's much easier to remember POEMS. But go ahead and look up FEMHI, F-E-E-M-H-I, if you are interested. Next question. What is a potential complication of lytic sarcoid lesions in the bones? What I am getting at here is that if you have lytic lesions in the bones, and if these are weight-bearing, you can have pathologic fractures from the osteolysis. And with sarcoid, these may not heal well, so you may end up with poorly aligned bones following pathologic fractures of sarcoid lytic lesions. Next question. I told you that sarcoid can present with sausage digits. What are differential considerations for a sausage digit? First, I would think of psoriatic arthritis with sausage digits. Think of this first before sarcoid or other causes. Then remember that other causes for a sausage digit include sarcoid, sickle cell anemia, tuberculosis, gout, osteomyelitis, and other causes. Next question. Can sarcoid cause arthritis? At this point, I assume you are just going to say yes no matter what, because that would be correct. Sarcoid could do just about anything, it seems. And sarcoid can cause arthritis, and you would most commonly see that in women under 40 years of age. And sarcoid arthritis would typically affect multiple joints and may present with joint pain, swelling, and erythema. Sarcoid arthritis usually resolves on its own within about 6 months, but chronic sarcoid arthritis can occur, although rare. Next question, what is Loof-Grin syndrome? L-O-F-G-R-E-N. L-O-F-G-R-E-N perhaps is an English spelling, but Loof-Grin syndrome. What is Loof-Grin syndrome? Loof-Grin syndrome is a form of acute systemic sarcoidosis that manifests with polyarthritis, erythema nodosum, which is a painful nodular red rash most commonly on the shins, fevers, and bilateral hilar adenopathy. Don't confuse this with Loof-Lur syndrome, which is pulmonary eosinophilia. Okay, Loof-Lur syndrome, pulmonary eosinophilia, Loof-Grin syndrome, acute systemic sarcoidosis that presents with polyarthritis, erythema nodosum, fevers, and bilateral hilar adenopathy. Loof-Grin syndrome is most common in women under 40 years of age. The polyarthritis of Loof-Grin syndrome is often symmetric and most commonly manifests in the ankles, but it can affect any joint. Loof-Grin syndrome is so specific for sarcoid that you may not need to biopsy to confirm the disease if you have this spectrum of symptoms. Take note that Loof-Grin syndrome is one of the only specific manifestations of sarcoidosis, and I think it is worth your time to know this. Next question. What are differential considerations for erythema nodosum? I told you erythema nodosum is a painful red nodular rash, most commonly presenting on the shins. And differential considerations for erythema nodosum are broad, but include post-streptococcal infection, tuberculosis, sarcoid, inflammatory bowel disease. It can happen normally with pregnancy, it can be a result of a drug reaction, or it can be a perineoplastic manifestation of leukemia or lymphoma. Next question. Can sarcoid affect the muscles? The answer, as you will guess, is yes. You can see single or multifocal muscular sarcoidosis. Look for soft tissue masses versus diffuse infiltrative lesions within the muscles. These most commonly involve the lower extremities due to granulomatous muscular infiltration. Next question. What are cutaneous manifestations of sarcoidosis? Cutaneous manifestations of sarcoidosis are broad, but can include nodules, plaques, papules, and so forth. Those specifics are more likely to be tested on a dermatology exam than a radiology board exam. However, remember that erythema nodosum can be seen with sarcoidosis, along with other skin manifestations. You can also have a lupus-like rash around the eyes and nasolabial fold with sarcoidosis. So if you see a lupus-like rash, but they give you other findings suggestive of sarcoidosis, remember that could be a cutaneous manifestation of sarcoidosis. What are common therapies to be aware of for sarcoidosis? For mild sarcoidosis, no therapy may be indicated. Steroid treatment is the main therapy for most cases and manifestations of sarcoidosis. More severe cases may start to add various immune modulating drugs, and end-stage sarcoidosis may require organ transplantation. Final question. Do we monitor sarcoid patients with imaging? And if so, how? Is any sort of imaging monitoring recommended for sarcoid patients? The strict answer is that there are no definite guidelines for monitoring sarcoid patients with imaging. However, I have read that many patients will have a chest radiograph about every 6 months, along with clinical follow-up and monitoring to check things like pulmonary function testing, renal function, calcium levels, EKG to evaluate for any cardiac disease, and so forth. That concludes my review of sarcoidosis for radiology board exams, at least for now. Thank you for listening. Keep up the good work. Check out my website for many free radiology board education materials, including a free downloadable study guide for this episode. Continue to study hard and prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.